Hello doctors, today we are going to discuss about the most important topic in our day-to-day life also and also for the exam, that is non-stress test. Where to read this? This non-stress test, it is beautifully given in areas. So what is non-stress test? This non-stress test, it indicates the fetal well-being. It indicates the fetal well-being. So let me show you this. You will be practicing in the day-to-day life. So this is the NST machine. This is the non-stress test. So this is the monitor here. This is to monitor the contractions, to look for any contractions, and this transducer is to note the fetal heartbeat. So this is about the non-stress test. It indicates the fetal well-being. So what is the principle for non-stress test? The fetal heart rate accelerations are studied in response to the fetal movements. The fetal heart rate accelerations are studied in response to the fetal movements. So whenever the fetus moves, there will be an increase in the heart rate. So that is studied in the CTG or NST. So what is the difference between NST and CTG? NST is a non-stress test. In this, you will be seeing about the fetal heart rate patterns. But in CTG, that is cardio tokogram. So this CTG, it is used in labor. Both are the same. But if you have want to analyze the heartbeat with respect to the uterine contractions, then you will be calling it as the CTG, that is cardiotocogram. It is used in the labor. That is the only difference. Rest all, the reading of the NST or the reading of the CTG is same. So what is the technique you are following? So as I have already shown you, there is a transabdominal Doppler. There is a transabdominal ultrasonic Doppler or transabdominal Doppler ultrasonic transducer is used to record the fetal heart rate. Is used to record the fetal heart rate. So I have already shown you in the image. So let me show you again. So this is the transabdominal Doppler to record the transabdominal Doppler ultrasound to record the fetal heart rate. This is to monitor the uterine contractions. Okay. Then a tokodynamometer is used, as we have already been shown. A tokodynamometer is already used to detect the uterine contractions. To detect the uterine contractions, a tokodynamometer is used. So what is the time of NST is 20 to 40 minutes. So normal time is for 20 minutes. If you have any doubt regarding the fetal heart rate or accelerations, then you will be continuing it for 40 minutes. And then mother will be given an event marker. Mother will be given an event marker to mark the every time the fetus moves. To mark every time the fetus moves. Every time the fetal movement is to be marked on the event marker. So what are the instruments or what are the things you will be seeing? A transabdominal Doppler to monitor the fetal heart rate, a tokodynamometer to see for the uterine contractions, and an event marker you will be giving. This is subjective, you will be giving to the mother. So what is the principle? The principle is response of the fetal heart rate to the fetal movements. It forms the basis of the NST. It forms the basis of the NST. So let us look about the components of NST. So what are the components of NST? In this, So here, let us look about the components of the NST. The first one is the variability. So what is variability? Minor fluctuations in the baseline fetal heart rate. Minor fluctuations in the baseline fetal heart rate is known as the variability. So this you are seeing, see this is the variability at about 3 to 5 or 10 to 15 beats. If you are seeing a difference, then it is known as the, so this is the variability. So how it is measured? It is measured by estimating the difference between the highest peak and lowest trough of the fluctuation. So what is how this variability sees is, it reassures integrity of the autonomic nervous system. It reassures integrity of the autonomic nervous system. So this variability, it reassures the integrity of the autonomic nervous system. Coming to the baseline fetal heart rate. So the baseline fetal heart rate, it is the fetal heart rate which is stable. The fetal heart rate which is stable excluding the accelerations and decelerations. The fetal heart rate which is stable excluding the accelerations and decelerations. Okay, excluding the accelerations and decelerations. Then what is the normal fetal heart rate? The normal fetal heart rate is 110 to 160 per minute. The normal fetal heart rate is 110 to 160 per minute. Then coming to the accelerations. So accelerations, this reassures the integrity of somatic nervous system. Okay, this reassures the integrity of the somatic nervous system. So what is an acceleration? It is a transient increase in the fetal heart rate. It is a transient increase in the fetal heart rate more than or equal to 15 beats per minute for at least greater than or equal to 15 seconds. For at least a period of more than or equal to 15 seconds. That is then acceleration. See in this picture, you will be seeing This one is an acceleration as it has increased from 150 to 170, that is more than 15 beats per minute for at least 15 seconds. So the next component is decelerations. So these are the components of NST. So what is a deceleration? Exactly opposite to the acceleration. There is a transient decrease in the fetal heart rate. There is a transient decrease in the fetal heart rate below the baseline for greater than or equal to 15 beats per minute for greater than or equal to 15 seconds. This is a deceleration. So in deceleration, you will be having types of deceleration. So these are very important. Early decelerations. So what are the early decelerations? The early decelerations, these are uniform, repetitive, periodic, symmetrical, and gradual decrease and return of the fetal heart rate. Gradual decrease and return of the fetal heart rate associated with the uterine contraction. So associated with the uterine contraction. So let me show you how this early deceleration looks. So these are the early decelerations. So here you can see these are the early decelerations. What we have told, there is a uniform, repetitive, periodic, symmetrical, and gradual decrease and return of the fetal heart rate associated with uterine contractions. So how this occurs? Early decelerations have an onset to the nadir, and nadir occurs at the same time as of the uterine contraction. See, this graph is more about the uterine contractions, and this is about the fetal heart rate. So this records the uterine contractions. So see, whenever there is a uterine contraction, there is a deceleration. So whenever there is a uterine contraction, there is a deceleration. So this shows the nadir or the drop occurs at the same time as of the contraction. Occurs at the same time as of uterine contraction. Then this is known as an early deceleration. In the early deceleration, what happens? Onset, nadir, and the recovery. It coincides with the beginning, peak, and ending of the uterine contraction. So this occurs in the early deceleration. This is also known as the mirror image deceleration. This is also known as the mirror image deceleration. Also known as mirror image deceleration. So what are the causes of the early deceleration? The most important cause is the head compression. The most important cause is the head compression. So usually this is normal in the pregnancy when there are early decelerations. Coming to the late deceleration. So this is about the early deceleration. Then coming to the late deceleration. So in the late deceleration, what happens? These are also uniform, periodic, repetitive slowing of the heart rate and the onset, nadir, and the recovery. They occur, once I show you the picture, you will be understanding it easily. They occur after the beginning, peak, and ending of the uterine contraction. Beginning, peak, and ending of the uterine contraction. So this is about the late deceleration. So this is the late deceleration. See. So when does this happen? This is the uterine contraction. So after the uterine contraction has occurred, then the deceleration has occurred. So whenever there is a completion of the uterine contraction, then there is a deceleration. So these are the late decelerations. They occur after the uterine contraction. So these are known as the late decelerations. So what are the causes for late deceleration? The causes are uteroplacental insufficiency. Uteroplacental insufficiency. The most important and the next important deceleration is the variable deceleration. The variable deceleration, it is an abrupt decrease in the fetal heart rate. It is not related to the contraction. It might occur before or after the contraction. Then so there is a variable deceleration, abrupt decrease in the fetal heart rate. The most common cause is the cord compression. Okay, the most common cause is the cord compression. Okay, then what is a prolonged deceleration? It is an abrupt decrease in the fetal heart rate less than 80 beats per minute. It becomes suspicious when there is if the fetal heart rate is decreased for less than 3 minutes. It becomes pathological if it decreases more than 3 minutes. Then coming to the another important pattern, that is sinusoidal pattern. In sinusoidal pattern, you will be having regular oscillation of the baseline. You will be having regular oscillation of the baseline resembling the sine wave pattern. So you will be having little baseline variability. So this is about the sinusoidal pattern. See this. You will be having a regular oscillation. Here you are having the oscillation of the baseline. It has a smooth undulating pattern. It has smooth undulating pattern lasting at least 10 minutes. Lasting at least 10 minutes. Okay, this is about the sinusoidal pattern. A sinusoidal pattern you can be seen in the anemia, fetal anemia or parvovirus infection. The sinusoidal pattern can be seen. So then, what is the classification of the MST? The classification of the MST is very much important. So by this, you will be deciding how to deliver or when to deliver or how to progress the labor. You can identify. So coming to the classification, everything will be recording. So this is the baseline. This is the variability, accelerations and decelerations. Okay, and then what is the feature? If it is a reassuring MST, then you will be having greater than 2 accelerations lasting for greater than or equal to 15 seconds. So what is a reassuring MST? In this, the baseline fetal heart rate will be 110 to 160. That is the normal fetal heart rate. And the variability will be of greater than 5. There will be no decelerations and accelerations will be plus, that is greater than or equal to 2 accelerations. So this is a reassuring MST. Then what is a non-reassuring MST? What is a non-reassuring MST? Either you may have a fetal brady or you may have fetal tachy. That is 110 to 109. That is 10 below, 10 less. And then 161 to 180. That is 20 above. 100 to 110 and 161 to 180. So this is the baseline fetal heart rate. This will be like this. And then variability less than 5 for greater than 40 minutes but less than 90 minutes. It means 40 minutes కంటే ఎక్కువ 5 వేరియబిలిటీ కంటే తక్కువ ఉంటుంది or 90 minutes కంటే తక్కువ ఉంటుంది. Then this will be the variability. in a non-reassuring fetal heart rate or a non-reassuring NST, then accelerations will be absent. There will not be any accelerations, and variable decelerations might be present. Variable decelerations over 50% of the contraction for greater than 90 minutes. Okay, 50% of the contraction for greater than 90 minutes. This is a non-reassuring NST. Then, what is a pathological NST? Coming to the pathological NST. So this should be marked in red as you have to act faster. So this is the pathological NST or abnormal NST. You will be calling it as abnormal. Okay, abnormal NST. So when you call it abnormal, when there is less than 100 or more than 180 or sinusoidal pattern for greater than 10 minutes, it is abnormal. Then less than 5 variability for greater than or equal to 90 minutes. And then accelerations will be absent. There is a atypical deceleration or variable deceleration or late deceleration in a 30-minute period, or you may have a single prolonged deceleration. So only one deceleration will be present, but it is more prolonged for greater than 3 minutes. Then you call it as a abnormal NST. So what is the CTG classification? So how will you classify this based on the NST? The CTG is normal if all the 4 components. So if all the 4 components are reassuring. So 4 components reassuring aithe, then this would be a normal CTG. When you call it as a suspicious, ante you will be waiting or you will be thinking at least one should be non-reassuring. At least one should be non-reassuring in a suspicious CTG. Coming to the pathological CTG. When will you call it pathological? Greater than or equal to 2. That is, at least 2 components should be non-reassuring, or at least one component should be abnormal. Either this might be present or these 2 factors might be present. Non-reassuring lo 2 factors anna undali, abnormal NST lo 1 factor anna undali. Then it is called as the pathological CTG. If there is a pathological CTG, immediate delivery is the only option. Okay, so this is all about the NST and CTG. Hope you enjoyed this class. Let me know if you have any doubts. Let us have a quick revision. Non-stress test. It indicates the fetal well-being. So this is the difference between the non-stress test and the cardiotocogram. So the technique will be having 3: transabdominal Doppler, tocodynamometer, and the event marker. So what are the components of the NST? Variability, baseline heart rate, accelerations, decelerations. So in decelerations, we'll be having early decelerations. In the early decelerations, onset, nadir, and the recovery coincide with the beginning and peak of the uterine contractions. Causes are the head compression. Late is the onset, nadir, and recovery. They occur after the uterine contraction. There is the beginning, peak, and ending of the uterine contraction. Example is uteroplacental insufficiency. Coming to the variable deceleration, there is an abrupt decrease in the fetal heart rate, that is cord compression. So I have a small technique for remembering these types of decelerations with examples. So in a normal delivery, what will come first? Head will come first. So head will come early. So early deceleration is seen in the head compression, only just for remembering sake. Then after head, what will come late? Placenta will come late. So placental insufficiency causes late decelerations. So cord might come variably. It might come earlier, it might come late. So you will be having a variable deceleration in the chord compression. It's easy to remember, that's all. Coming to the sinusoidal, regular oscillating pattern, you will be having a smooth undulating pattern. Next, coming to the classification of the NST based on reassuring, non-reassuring and abnormal NST, you will be calling it as normal, suspicious and the pathological CTG. If all the four are reassuring, then you will be calling it as normal. If at least one is non-reassuring, you will be calling it as suspicious. If greater than or equal to 2 are non-reassuring or greater than or equal to 1 is abnormal, then you will be calling it as a pathological CTG. Hope you liked this class. Thank you for your hearing.